the annual Evelyn Lee Visiting Scholar Lectureship in Cultural Competency and Diversity. Thank you. We wanted to make sure everyone was awake when we're starting at 8:30. It's sponsored by the Department of Psychiatry and is organized by the Diversity Committee. And it's in remembrance of Evelyn Lee. She served as a clinical faculty member for more than 20 years before her passing in 2003. And this lectureship is dedicated to her mission of expanding diversity, equity, and inclusion in the field of mental health by bringing prominent experts to share their experiences and expertise with campus trainees, faculty, and staff. For these kinds of lectures, I think it is important for us to kind of understand the history. So I just want to tell you a little bit about Dr. Lee. She received her BA in social work in Hong Kong in 1963, went on to graduate from Case Western Reserve with a degree in social work in 1968, and then obtained a doctorate in mental health administration from the University of Massachusetts, Amherst. She joined our faculty in 1982 when she took leadership of the Asian-focused psychiatry inpatient unit at San Francisco General Hospital, and she was appointed an assistant clinical professor at that time. In 1999, she was promoted to clinical professor of psychiatry, where she served as a consultant on cultural competency and diversity for many community mental health and health organizations, schools, hospitals, local, state, and federal government agencies. Throughout her career, she wrote actively and taught on topics such as cross-cultural communication, including the use of interpreters, refugee trauma, immigrant acculturation, intergenerational conflict resolution, the role of religion, and complementary alternative and integrative medicine approaches. In '88, she authored a widely used parenting handbook in the '80s, the 10 Principles for Raising Chinese American Teens, which was subsequently translated both into Chinese and Vietnamese. She was widely respected and loved at UCSF in the mental health field and in the Asian American community as a clinician, administrator, teacher, author, community advocate, and humanitarian. And this lectureship is, as I said, designed to help continue her legacy. I also want to say just very briefly that there has been no moment in time that I can think of that it's more important for our department to celebrate diversity, inclusion, and equity, and I, both individually, also as a department, and I pledge to you that we will redouble our efforts in that regard. Christina.
Thank you so much, Matt, and it is an honor to get to both remember Dr. Evelyn Lee, but also get to introduce you to Dr. Eliseo Peréz-Stable. Dr. Peréz-Stable is the director of the National Institute on Minority Health and Health Disparities at NIH. This institute actually helps plan, review, coordinate, and evaluate all minority health and disparities research activities conducted in NIH. So it's a big job, and he's a man who's well suited for this role, as he's had his research expertise spans a broad range of health disparities research and disciplines. He's worked on advancing patient-centered care, communication skills, and promoting diversity in biomedical research workforce. He's a real leader, actually, in Latino healthcare and disparities research, spending more than 30 years leading research on smoking cessation and tobacco control policy, and made real impact with his science nationally and internationally. So as an example of this, he's co-principal investigator of Redes en Acción, the National Latinos Cancer Control Research and Education Network, which is funded by NCI, and that actually led to him spearheading the development of a research agenda on tobacco control for minority populations here in the U.S. Through his collaborations and his science, he also actually put tobacco control policy and work on the map in Argentina, and it's really quite notable. It's not surprising that Dr. Peréz-Stable has received numerous honors and awards, and including election into the National Academy of Medicine. But one of the things that makes me very proud to have him coming here is he's coming home to UCSF. So he began his career doing residency in internal medicine here at UCSF, and and then rose to become the division chief of general internal medicine based here at Parnassus. He was also director of the Center for Aging in Diverse Communities, the CADC, as well as MERCY, which is a Medical Effectiveness Research Center for Diverse Populations. Through CADC and MERCY, Dr. Peréz continued his commitment to developing a diverse workforce in scientific research by mentoring and collaborating with many minority faculty. And I'm just personally honored to have been one of his mentees. He was a sponsor for me very early on in my career at UCSF. I remember going to his office here at Parnassus, him looking through my CV, directing me to different opportunities at UCSF, and eventually receiving one of the pilot grants through CADC that led to some findings that helped me get a K award. So I'm personally indebted to him as well. And he really is the quadruple threat. Not only is he an excellent clinician, educator, a fantastic scientist, but also diversity, inclusion, and equity is just infused in all of the work that he does. And so it's my absolute honor to have him here today and for us to learn from him. So welcome, help me welcome him.
So good morning, everybody, and it's a real honor and pleasure to be here back at UCSF to give a talk. I actually knew Dr. Lee when I was an assistant professor at UCSF. She asked me to give a talk in her course. And so when you asked me to do this, it did bring back memories. And my links to the Department of Psychiatry goes back to my early days at UCSF, as I have a very long and close collaboration with Dr. Ricardo Munoz, who I know he couldn't be here today, but he did send me some materials. And looking up Dr. Lee, I acknowledge her many contributions to this field. I modified the talk slightly in her honor, but I'll see how it turns out. And I want to thank Dr. State also for hosting me, and it's a real pleasure to be here. I'm going to try to cover a lot of things in the next 40 minutes or so, and hopefully we'll have time for some conversation. The other two places I'm speaking today are slightly different, but this beginning part is pretty identical. I want to start always with a history of who NIMHD is. We were established as an office in 1990 under the Secretary Sullivan, and then in the year 2000, the critical transition was that the office was changed to a center. We were now given a budget, appropriations, and we're able to give grants. In 2010, the center was elevated to an institute, and so we are the newest institute at NIH. This was part of the Affordable Care Act. And I asked the same question you're thinking right now 2 years ago, but I believe that now it's well established in the ingrain of appropriations, so we're okay. John Ruffin was the director of the office until he retired of the center and the institute, and I started just a little bit over 3 years ago. So minority health is really to focus on research that is specific to outcomes within any of the race ethnic minority groups, and I'll review them in a minute, in comparison to others or to a reference group, whites, whether the outcomes are good or not. And I think that's the important point there. And then race and ethnic minorities, we believe, share a common disadvantage based on being subject to discrimination as a common theme, and I'll talk more about this in the talk. These are the categories from OMB, the Office of Management and Budget. This is what we adhere to. It's what the census asked. There were some proposals to modify it, but that did not happen. These are the terminology that is used, in case you're interested and want to abide by federal guidelines. There are some comments I'll make. Asian is a very heterogeneous and challenging group. In fact, South Asians are included there for geographic reasons, but they really are very different and should be separate, but that's the way it is. Native Hawaiian and other Pacific Islanders are not Asian, which is commonly lumped together, and they are different in many ways, including from the genetic perspective. American Indian Alaska Native, of course, is a small group. You don't notice them as much in California. I can tell you that from a national stage, this is a big deal, and I think there's a historical legacy there that for which we have a common responsibility that we need to address. Latinos and Hispanics is the only ethnic group recognized in this categories, and then whites, which actually includes people from the Middle East and North Africa. You think, well, we're past race, right? Why do we even bother with this crude self-reported construct. Life expectancy in the U.S. is driven in part by this crude self-reported construct. If you look at whites living on average 4 years longer than whites, if they're male, about 3 years longer if you're a woman. This gap has actually narrowed substantially, as I'll go over, for a couple of reasons. And then Latinos defy any modeling or expectations because they live longer, even though the socioeconomic status disadvantage is clear. And no one has an explanation for that still. And the data on American Indian, Alaska Native, Native Hawaiians is not national. These are estimates that I saw in a presentation from the census people. But you can see this tremendous disparity that exists there. This is black-white mortality in the U.S. In the last 2 decades, roughly, so from 2000 to 2015, I think, is there. And notice that for people over 65, African Americans actually live longer. Isn't that interesting? That was not true, by the way, back here in 1999-2000. So progress has been made. Significant progress has been made. The big gap remains in the midlife, and there's always gaps in infant mortality. So health disparity populations per NIH is as follows: race, ethnic minorities, all of the ones identified by OMB, poor people of any race, ethnicity, so less privileged socioeconomic status, people in rural areas. This was part of our legislation and clearly a strategic group right now, and important. And then sexual gender minorities that we declared 2 years ago as a disparity population for NIH research purposes. And we define a health disparity as an outcome that is worse in these populations compared to a referent group. So the fact that white men have more heart attacks is a difference, not a disparity. And I think that we've tried to support this kind of definition. Now, a lot of the audiences I speak to wonder about, socioeconomic status, how relevant that is as a population and clinical scientists over the many years. This fact is brought home by this graph, this simple graph, is a relative risk of all-cause mortality by U.S. annual household income. And if you are at the poverty level, roughly, which is $25,000 for a household, you're 3 times more likely to die from anything than if your household income is $115,000, which is, as you well know, in San Francisco especially, is not wealthy. So this is not the 1%. And you can see this very robust gradient. So I would argue this is as important as BMI, as blood pressure, as any metric that we use routinely in clinical medicine. It should be included some aspect of socioeconomic status. Now, most people don't like to say how much money they make or don't make, so we will often use education as a substitute for SES, which I think is pretty good. These are other categories. The point here is that it's ultimately all about wealth, and it's really hard to get at wealth in a clinical or a human research context without getting into too many measures and details. But these are all different aspects that have been used in different areas of research across the many years. But ultimately, it's really about wealth. There are many other social determinants of health, and I think in the minority health disparities field, originally this was our foundation, is look at the social determinants, the demographic ones, including national origin, where you live, cultural identity, religion, immigration status, language proficiency, literacy, food insecurity, housing security, sexual orientation, and gender identity. At NIMHD, we have embraced the concept that to look at mechanisms leading to health disparities, we look at 4 different big areas added to the clinical context, as I'll show you in our framework. But originally, much of the health disparities research focused on individual behaviors and lifestyle, but we know there's so much more there regarding to childhood adverse conditions, responses to stress, and other different stresses that are introduced in the individual. In the last 20 years, the explosion of information from the biological processes has really been quite humbling, starting perhaps with the Human Genome Project, but really expanding from that, and it's still going on. So for those of you who are not basic scientists or not tuned into the biology of what's going on, you should, because there's a lot happening. The Brain Initiative and a variety of things are on extracellular RNA, and other things that are coming down the pike. We need to keep track of that. The physical environment is a parallel area of research that, if you go back to the 1990s, there hardly was a literature. on place and health. And today, I can say very convincingly that your zip code is more important for your health than your genetic code. And that's a direct consequence of this research on the built environment. And we've known for decades that cultural interactions, that interacting with people in a positive way is good for your health. And blending these two together and how we capture these social interactions in a network and cohesion in communities is important. I'm a general internist, and so for me the clinical setting is a critical one, and so studying what goes on in the urgent care and primary care and specialty care and the hospital are important for defining and ameliorating or addressing issues around health disparities in looking at healthcare equity. We have this framework on our website. It was really generated by our scientific staff. I had worked on a framework for the National Institute on Aging when I was on council there, and we published that before I moved to NIH, so this was one of the first projects we did. And we urge all of our potential applicants to refer to it or to look at it and see where you fit. It's not comprehensive, it's not causal, but it really tries to capture both the science and the complexity of the topics that we're interested in. So NIMHD has been in the process of being reorganized. It's a long process in government, especially for our institute, but we created 3 functional divisions within the Division of Scientific Programs. These are the scientists who basically manage the grants that we award. So it's the heart and core of what NIMHD is about. So we give grants, and then for 5 years usually R01s, and so this is where they're managed. So we have a clinical and health services research to capture this clinical arena. We have biology and behavioral sciences, sort of mechanistic division, and then community health and population sciences that reflects the history of our institute in working in community-based participatory research, and also add the component of population science, and particularly around big data. We have a number of funding opportunity announcements that are published. The only one on this list that is not yet officially out is the Health Information Technologies one. It's been approved by Council. There's a draft in the pipeline. It'll probably come out sometime in December. Keep in mind that these are funding opportunity announcements, so we basically put out announcements that we're interested in grants or applications in this area. We very much adhere to the R01 fundamental contributor to advancing science, and we've transitioned the Institute from a more center-heavy set-asides to a higher proportion of our budget now is allocated to R1s. But this gives you a sense, a flavor of the kinds of things that we are interested in. Some of them are in collaboration with other institutes, and some of the sort of, I would say, frontier topics like sleep, disparities, social epigenomics, and then, of course, the opioid use disorders, of which I'll talk a lot more this afternoon at the VA. This is just an example of some of the grants that we fund in mental health. It's not comprehensive, but there's probably not that many more. Remember, we're a small institute compared to any of the others, so our budgets, I didn't say, is $310 million compared to almost $6 billion for the National Cancer Institute or the Institute of National Allergy and Infectious Disease Institute. But this gives you a sense of the variety of things. A lot of issues on behavioral change, a lot of topics based in the community, not yet anything concrete in the clinical setting, which I think is ripe for funding. So let me review some of the sort of high-level topics in mental health. This is the prevalence of depression in the U.S. As recently as February of this year by race, and you can see that, of course, there's a gender difference in all the race ethnic groups, but there's not really much difference here of any of the groups. Slightly higher for African Americans, perhaps, but that's really not significant. Latinos and whites similarly. So this is a diagnosed major depression in the previous 2 weeks. Asians and Pacific Islanders are low, although there's always question about the adequate sampling of non-English speaking Asians in these national surveys done by the CDC, since they are not done in other languages than English and Spanish. This is suicide, and here we see a big difference. And this is an unanswered observation that is now quite consistent for several decades. So whites and American Indians, Alaska Natives have much higher rates of completed suicide in the U.S., and blacks and Latinos and Asians, Pacific Islanders, have much lower rates that haven't really changed in the last 20 years. So from 1999 to 2007, and then the grouping 2008 to 2015, you can see the numbers there. A lot of interest in why the rates are going up, and again, that's a topic for further discussion, I think, again this afternoon. And for American Indian, Alaska Native, it's one of the stress signals coming from this population that I think we need to pay attention to. But isn't that interesting that for the minority groups, particularly the disadvantaged, the unequivocally disadvantaged African Americans and Latinos compared to whites, it's 1/3 the rate. This is not a subtle difference. This is like big time. It's hitting you over the head. What is going on here? You're the psychiatrist, right? So figure it out. This is a huge challenge. I asked Josh Gordon, UCSF graduate, who's director of NIMHD, and of course he doesn't have an answer for this either. But I think it's fascinating. This is the same data, slightly differently analyzed from CDC, looking at urbanization. And here, the second number is those who live in more rural areas. About 18% of the U.S. population lives in non-urban areas. Only about 6% live in true rural areas. But you can see here the trend that if you're in a rural area, except for blacks, the rates are higher for all groups. And so there is, I think, evidence in this context of more problems or distress in people who live in rural areas. Now, one topic I'm not going to spend a lot of time on in any of the talks is around diverse participants in studies. I think this is a historically important area to focus on. It has gotten the most press in the last 5 years, I would say, around the genetic data. The GWAS data is predominantly European, although NIH has done a lot to try and remedy that. The changes that happened mostly came because of East Asia. East Asian countries doing it, but not Latino populations or Latin America or African Americans in the U.S. Inclusion is really important. It's part of our interest, part of our mandate, but it is separate from research. If you have a great study and you do have a diverse sample, it's not minority health research unless you're asking a question about minority health. But it is a mandate that any clinical study should have diverse population. And part of that is social justice. You say, well, 40% of the U.S. population is non-white. We shouldn't have studies that don't look a little bit like the rest of the population. And if you wonder about what's going to happen there, 50% of the U.S. population now of children are non-white. So, kids do tend to grow up. So things are going to change even more. But it also is good science. There is discovery that's left on the table if we do not have diversity in our samples. And you can't power every clinical study to look at different race ethnic groups, but if you don't have anybody in your sample, or very few, you really won't be able to even detect obvious things. And again, I would explore that further perhaps in the questions. About a quarter of all participants in human research funded by NIH and a cross-sectional view are from one of the race ethnic minority groups. So it's not terrible nowadays, but it could be still better. There isn't a whole lot of science of what it takes to recruit diverse participants. Everyone acknowledges it's harder. It often takes different skills. It often takes more resources because investigators aren't used to working with these communities or with these participants. I can say just anecdotally that we think that it takes more face time, that you have to sort of go to the sites and talk to people. They want to see the scientist, not your research coordinator. And not being of the group is not necessarily a bad thing. You just have to be able to develop more trust. We think minority scientists are better at it, but of course that's a biased opinion and there's no empirical evidence to support that. And I also think we need a lot more granularity in our participants. I'd love to see NIH require investigators to report not just race ethnicity as people are currently required to do, but also some measure of socioeconomic status, and then added birthplace and language would be good. But it's also important to create some level of PI accountability. Currently, none exist. your grant is funded. Nobody ever really checks whether you recruited the participants you said you were going to recruit in your application. Just the numbers, that's what you worry about. But no one ever really checks whether you actually got as many minorities as you originally said. And there's no system right now to monitor that, although we have the capacity to do that. I think I duplicated that one. Okay. No, I'm going backwards. Okay. I'm sorry. There we go. So, snapshot of any mental illness in the past year. This comes from SAMHSA, and it's from 2008, 2012. And then the second column is anyone receiving services if they have a mental illness. So if you look at just the snapshot, prevalence rates may be lower for Asians, although again there's probably some methodological issues there in terms of language and adaptation of diagnostic measures, but not big dramatic differences. I self-reported by race ethnic group, 15% versus 19% for Latinos and whites, modest differences. The big gap is in getting services, and at least in my current perspective on both severe mental illness and except for what I showed you on suicide, and there are a couple other things that we could talk about, is that the race ethnic differences are not as dramatic as they may be for other conditions like diabetes and some cancers, but there's a big barrier and gap in access to services and obtaining services, whether it be behavioral or pharmacological. So this access is the big challenge, and it's been, I think, discussed a lot in the literature. Minority groups have a disproportionate burden of disability, and I think predominantly is due to lack of treatment. Again, there's not a robust empirical literature behind this other than, yes, diagnosis is less frequent. There are some questions about overdiagnosis of, let's say, major psychiatric disorders, schizophrenia in particular among African Americans, but not as many differences there as one would have thought possible. Of course, there are differences in autism going in the other direction. White Americans have higher rates of autism. Criminal justice system, which I'm not going to dwell on again, is another topic where this intersects enormously. And the main way it intersects is that, as I heard a judge from South Florida say at NIH at a conference we had on opioid use disorder, he says, well, the criminal justice system has become the psychiatric care of people, as well as the addiction care of people, because most of the people he saw through his court either had an addiction issue or had a major psychiatric problem. And you know that disproportionately Latinos and African American, particularly men, are overrepresented in our criminal justice system. So this is where this intersection exists. There is interest at NIH in this. NIDA in particular, as well as us, are interested in this, and other institutes as well. And then our understanding of the impact of adverse events in childhood really is an illuminating mechanistic pathway to understand what happens to adults. And perhaps in this case, major mental disorders really led the way for this understanding, although we now believe that things that happen to you at age 2 or 3, or perhaps even in utero, is what increases the chances of developing things like obesity, diabetes, cancer, and heart disease when you're an adult. And then, in addition, psychiatry has always had some challenges in the minority populations with stigma. It continues to be a stigmatized diagnosis. We've seen this very clearly with the opioid use disorder epidemic and how addiction, defining it as a brain disease, helps as opposed to a social and moral failure, which is what society believes it is. If you're addicted to a substance, it's because somehow you as an individual failed. And I think attacking that stereotype, I think, is a critical part of it. And there are cultural barriers, particularly in some groups more than others, with regards to obtaining psychological or psychiatric help. But in promoting health equity in healthcare to reduce health disparities, these are sort of global points that actually involve general health care, not just psychiatric care. And access expansion is really critical. We're going to be able to see more of what happened when we have the health insurance coverage for the U.S. population. We decreased the uninsured, as part of the Affordable Care Act that really was sort of deployed technically in 2014. And people forget that. So we've only now about 4 or 5 years out from actual implementation of expanded Medicaid, and see what's going to happen with that. There are things that we know what to do, and we should just do it, like treating hypertension or controlling diabetes. And I think in psychiatry, you can certainly come up with parallels, whether it be treatment of major depression or management of individuals addicted to substances. Coordination of care is critical. I think one of the big differences I see in the Northeast or the Mid-Atlantic, where I'm living now, is how limited this concept is accepted in clinical care. I'm not referring to research in that area of the country as compared to California. And I think we're well ahead in that regards. And then patient-centered care, the importance of primary care, and the power of effective communication and cultural competence that comes with that. Again, in homage to Dr. Lee and her life's work, I think this is a critical area that will be a mechanism for helping reduce disparities. I want to spend a few minutes talking about racism as a research construct and how critical it is for us to conceptualize this and study it more empirically. Most of what you have heard people have published on racism is in that interpersonal categories when we develop scales that people ask you about perceived discrimination, whether it be in the last month or the last year or in your lifetime. David Williams and others, I'm forgetting now all the people who've worked on these measures, everyday discrimination scale. There are good measures out there that people use in research, and there are clear associations that have been established. Structural racism is not necessarily easy to conceptualize as a research construct, but this really reflects the history and culture of institutions that were codified in practices. And again, another aspect of our society that I have learned in the last 3 years, being from San Francisco most of my life and then moving to Washington, D.C., is the legacy of slavery and the situation of African Americans in this country, and how the Civil War really never ended. And you don't get that here in California. I mean, it's a big difference living in the Northeast. And I think people tend to sort of say, well, you know, that was a century ago. We beyond that, you know, especially after the election of Barack Obama in 2008. And we really are just confronting this as a society, I think, every day. And then internalized racism, which is when someone says, nope, never been a victim, no, right, I'm not, nobody's been a racist around me, but yet you react to that and you adapt. And we now understand that the biology of stress, you know, if you think about racism as a form of chronic stress, I think that's the way I would adapt it. Researching on structural racism is harder. Now, you say, well, this is not that common. This is a Kaiser Foundation survey of Americans from 2015, so only 3 years ago. And they asked in the past 30 days, were you treated unfairly because of race or ethnic background in store, work, entertainment place, dealing with police, or getting health care? And you can see that over 50% of African Americans say yes to this. So this is not uncommon. This is really sort of every day for the black population in this country. Over a third of Latinos respond also yes, and whites is about 15%. Most of the whites' discrimination is usually around socioeconomic issues, but it can also be race. And then the second column is health, and yes, we're doing a lot better, but still 14-12% is higher than it should be. You say, well, how does racial inequity harm health? I talked about the measures, and you can look those up. There is a fair amount of literature on effect on physical and mental health status of African Americans, both from observational cohort studies, so not just cross-sectional studies. There are also good studies on physiological measures such as systolic blood pressure and level inflammatory markers. The link on mental health to heart disease, so the idea that you experience racism, discrimination, you get more stress, it affects your mental health, and then there's been research on linking that to cardiovascular outcomes. And then how discrimination impacts health behaviors. There's a lot of more literature here where if you perceive or have been susceptible to racism discrimination, you're more likely to smoke tobacco, have problem drinking, and use other substances. The data that link this event over here, perceived discrimination, racism, to a heart attack or diabetes or major depression are not as robust. So the clinical outcome connection of that line is not clear. And again, research that could be expanded on. I want to highlight this study that was published a year ago in Social Science and Medicine. It's a longitudinal study, the National Longitudinal Survey of Youth, Parents, and Children, very diverse, and then there's a long-term follow-up. And one of the values of this study, besides its observational design and longitudinal design, is that it actually included a fair number of not poor minorities. So blacks and Latinos in this study, many of them were moving up the socioeconomic ladder. And what they found was that for this group, as they had increased SES, for whites they had less discrimination. For Latinos and blacks, they actually experienced more discrimination. And this is a recent observation I think is worth further exploration. One of our scientists at NIMHD says, well, do you believe the paper? Well, David Williams is a senior author, so I do. But of course, we're scientists, so everything's empirical, and you have to see what other research data out there can explain this. And there is a paucity of studies on more middle class, if you want to use that term, blacks and Latinos in this country. It just doesn't exist. There are a couple data sets. AdHealth in particular comes to mind as potential for future research in this area. This is an example that was done by the group at Michigan. Anna Diaz-Ruz was a senior author of looking at an existing cardiovascular cohort, CARDIA, and correlating the level of blood pressure with what was used as a measure of, if you wish, of structural discrimination, which was segregated neighborhoods, which is often a sociologist approach to this, looking at areas of where people live that were above a certain percent of one race or another, and its effect on blood pressure. This is a more recent study out of Southern California, which I think is also interesting in this regard. It's a large survey of 11th to 12th graders, so it's a one-year follow-up. And they asked a question that is listed there, concern, worry, or stress regarding increased hostility and discrimination regarding race, ethnicity, sexual orientation, identity, immigrant status, religion, disability. So global perception, not of how you respond, but how the students, these are youth, remember, 15, 16 years old, how they perceive society. So what's going on out there, how they perceive it. And it was perceived societal discrimination is common. 40% of the sample responded that they saw this. You can see the diversity of the sample. This is in Los Angeles County, the study. And it was associated with increased substance use, in this case primarily tobacco, cannabis, and alcohol. There is the study we funded that looked at suicidal the self-reported discrimination was correlated with suicidal ideation in this group of 3,000 plus Chinese adults over the age of 60 from the Chicago area. And so this is not necessarily only an African American issue, so to speak. This is something all minorities report on. It probably has gradients and different levels depending on the part of the country. But this is not something made up, and this is not something we're done with. It exists in our country as well as globally, and I think this kind of research, I think, is a critical one. I'll switch gears now and talk about patient-clinician communication. As I mentioned before, I'm a general internist, so I have a strong, I enthusiastically embrace this as an important core of our healthcare system. Having a trusted relationship with a clinician, usually a physician, but not always. It is, I think, empirical that you can see improvement in patient satisfaction, better adherence, and better health outcomes when there is a strong, particularly primary care relationship. It also expands to specialty care. This is an old survey from the Commonwealth Fund asking a large sample of Americans about, do you understand what your doctor says? Did your doctor not listen to you, or did you have questions they would not ask? Something I think all of you, either as patients or as physicians or clinicians, have experienced. And you see this race differential. So again, whites are less likely to say yes to any of these questions. African Americans, Latinos, and Asians more likely. Lisa Cooper, who's at Hopkins, has done some elegant studies that were quite tedious, doing qualitative analysis of patient-clinician interactions, showed that race concordance actually did improve, led to more patient-centered care, more time. The clinicians spent more time with their patient when there was race concordance, and the patients had higher level of satisfaction. The big challenge is does this matter to clinical outcomes? And I can't say that it does. And I think later this morning at the San Francisco General, I will discuss more on the diversity of the workforce and the evidence for doing that, which is independent of that empirical literature. Again, in an area I've been very involved with in the past regarding to limited English proficiency status and health outcomes, and again in a homage to Dr. Lee's career and work, and one of the reasons I gave a talk in her course. What is the impact of having limited English proficiency? And there is an empirical literature. Can't do a randomized trial here, sorry. But you can do a lot of good observational studies and define your predictions and outcomes in a good way. And briefly just state that it is associated with less communication between clinician and patient. Actually, a lot of the early work of this came out of the psychiatric literature, psychotherapy literature. Can you imagine doing psychoanalysis, if you wish, or any kind of counseling with someone when you don't speak their language? And using interpreters is really inadequate there. But there is, I think, some empirical literature in this area. Language concordance is a challenge. Language concordance is common. It's not going to go away. Interpreters are often not available, infrequently used, and often not trained. I mean, UCSF did embrace this as an unfunded mandate, and is critical. We also did some empirical work showing that language concordance was more patient-centered, and others have done this as well. In brief, you can see better glucose control, particularly around diabetes. There's the more empirical literature on this coming out of Kaiser, some of the work done locally by Eliseo Fernandez and others. Early on, we did a study which showed that patients who had a language concordant clinician in our practice felt better, had less pain, and better health outlook using medical outcome studies measures. They clearly can understand more of the physician instructions, and this has been studied with qualitative work. And then better medication adherence. All of these findings are relevant to all clinical care. All of these studies were mostly done in Spanish-speaking patients compared to English-speaking, so there's not a lot of empirical literature on non-Spanish speaking limited English proficiency patients. And I think it's all applicable to all kinds of psychiatric care as well as specialty care and hospital care. If you have concordance, patients, again, shown in qualitative studies, and these are not even chronically ill patients, ask more questions. And it's more patient-centered by all the metrics that you can use to say what's a patient-centered interaction. So I think this can be an effective and powerful intervention to reduce health disparities. Now, based on the empirical literature, I can say, well, professional interpreters should always be used whenever possible. It's really about quality. It's really inadequate to have an interpreter, have a non-professional interpreter help you decide about clinical care. And I saw this most important in the hospital, in my experience at UCSF. Health systems need to support the increased access. I think UCSF has done that. With the video medical interpretation that was developed and used in clinics, and then in the inpatient setting, the dual handset telephone. Again, we did empirical work on this, and then provide more time. So if I actually say, I used to save the system an interpreter when I saw half of my patients in primary care spoke Spanish, so they didn't need to get an interpreter for me. The residents did. So we actually saving the system some funding, even though that no one pays for interpreters, of course. But you do need either to get more time, which is not unlikely to happen, or be recognized with compensation. And I think that when I left 3 years ago, this was actually being worked on by the UCSF Health. They were actually in favor of it. There were some other issues they needed to deal with at the time. I'll mention the unconscious bias. This has become sort of prevalent. It's not an easy fix. It's not the magic bullet, but it is, I think, a useful tool, particularly to raise awareness among faculty and clinicians. But it has been tried in a variety of research settings. Back in 1999, Kevin Schulman published a paper in the New England Journal about the effect of race and sex on physician recommendations for cardiac cath. And patients were actually, it was scenario videos that they showed at different meetings. And black women were less likely to be referred for angiography. Everyone had the same story, chest pain, typical angina. And at that time, unlike today, the standard of care was that everyone with suspected coronary artery disease should be referred to a cardiologist for a revascularization procedure. We know better now. But there was a clear race and gender barrier there. So people are saying, well, it's just unconscious bias, retrospectively explaining that. A variety of studies have been done, nothing very convincing, although it is an attractive hypothesis to explain why we see less likely that minority patients are referred for technical procedures, and there's the literature on lung cancer surgery and renal transplant as well as cardiac surgery. And then a number of clinical studies have been published, too, that found bias favoring treatment of whites. Most of these actually have been done in the emergency department as opposed to in other settings. And community engagement is very much central to NIMHD's focus, and I think to all NIH institutes that focus on population health. And it's really shifting models to define populations. And I think that's a good way to think about our clinical community interaction. There's a lot of opportunity in the electronic medical record. I can't tell practicing clinician that because everyone's drowning in it, but I think as we emerge from this initial uptake phase, the potential for a portal for patients, e-referrals, telemedicine, et cetera, even within an urban environment like San Francisco is there. And similarly, we need to address issues around real food and safe places for our communities. We now understand how important this is, although it's hard to empirically show that, a food desert causes obesity, and people have abandoned that sort of idea that, oh yeah, we can now demonstrate why we have this epidemic of obesity. But it is still important that people need to eat real food and be able to live in safe areas. And then the issues around discrimination I mentioned. Health IT, I think, can be a powerful way to intervene. We have to start by doing the basic things well and have standardized measures incorporated into that electronic health record. We do a better job of measuring race, ethnicity, but I would say I'm really been away from clinical medicine for 3 years, so I don't know what's going on in detail. I doubt that we're doing much better job of collecting socioeconomic status. Now you can do proxies with insurance. You can also impute the zip code into census data, so you can get imputed value, which is pretty good. But I think that showing you the importance of this in health, I think is something we ought to be doing. And how the portal can be used as a way to access communication for patients, and the potential for doing better communication for limited English proficiency, people who have limited literacy, using video and other languages. So I think this is all to be done. Now, when I got to NIH 3 years ago, all the buzz was about precision medicine, the Precision Medicine Initiative. We now call it All of Us. Even Francis Collins says it's not a genetic study. It's really the mother of all cohort studies for the U.S. Over 100,000 people have already been enrolled, not fully through the initial process, and that train has left the station. But I want to point out that we're not there yet, except for cancer. And everybody thinks, oh, I'm going to come and bring my biological information to my doctor, and he or she will really know what drug to use for my blood pressure, or which drug works for my diabetes, or which one works for my pain. And maybe that's a goal of where we're headed, but we're not there yet. Keep in mind that new is not always better, and it's almost always more expensive, and we're dealing with a major crisis in healthcare costs that has not been addressed by anyone. And that we do need precision in patient-clinician interactions as well. So I would argue that one-size-fits-all works really well sometimes. And it's on us, the scientists, to really show that the precision is better, as you're seeing emerging in some of the issues around cancer. And finally, from an NIMHD perspective, these are just some global, again, high-level thoughts on where research needs to move. Everyone talks about multi-level interventions needed to address, and it's not that complicated. I mean, it's like if you intervene in a healthcare system, you have to maybe intervene in the system with clinicians and with patients, or with other clinicians, not just doctors, or maybe community, and as well as medication or therapeutic intervention that you do. That we really, really need to do more fundamental work that is not going to cost as much as some people think, to understand mechanisms better and know what factors are contributing to disparities. For some we know the answer, we think, but many others we don't. And I showed you a couple where it's these glaring differences and we don't understand why these things are happening. When people, and scientists I've noticed, when they don't really understand what's going on and they just kind of ignore it. They just go on to the next thing that they do know something about, because nobody likes to get up and say, well, we really don't know anything about this. I think that assessing and using communication strategies more effectively is, again, not new. This is old. This is low tech. But this really could potentially be a very powerful therapeutic. And then I'm a big proponent of implementing structural change to modify behavior. I would say that it worked for me as a division chief with faculty and at NIMHD as a director. But I think in society it can also work. One quick anecdote on that, it was a study that we funded, again, in Southern California on kids sort of decreasing their intake of sugar-sweetened beverages and impacting their ability to gain weight. And there was all this educational and cultural intervention in the high school, I think middle school level. And it turned out that the component of the intervention that seemed to be most effective after they finished the study was giving them access to water. So, the old water fountain that used to exist in everywhere when I first came to the U.S. It was just, bottled water or whatever, chilled water, that really was the main thing that worked for them. So thank you for your attention. I think we have a little time for questions here. Yeah.
Hi, thank you so much for being here. It's great to have you back. I noted in the beginning that you talked about the evolution of the focus on disparities and that it now includes things such as sexual and gender minorities. And yet through the bulk of your talk, it wasn't explicitly referenced or addressed. Can you speak to the Institute's attitudes and ideals around supporting that research, especially in light of current controversy?
Right. What controversy? So when I got to NIH, this had been a hot topic of discussion, and I got all the credit, but really did very little of the work. Just to put it in perspective and context, so NIH had been, there was a commissioned National Academy report, I think from 2012, that basically said there's no data, and we need to do more research. And so NIH used that as, we want to declare as sexual gender minorities, this is the NIH terminology, not LGBT, whatever, to declare them a disparity population so that we could shine more light on this issue and develop an empirical literature to support whether or not this is there are health disparities around this. So Larry Tabak, who's the principal deputy at NIH, sort of presented me about a month and a half after I was there, do you support this? And I asked staff, and everybody said, yeah, we support it. So they submitted. Well, it got rejected at the department. This is in the prior administration. So they were very hesitant to endorse this, in part because of constituents, saying, well, the pie is only so big, and now you're going to add another slice to give to someone else. And this was the perspective we think, although nobody ever admits that. But we repackaged it, and I think that the critical part, is people say, well, what's the mortality of this? What's the mortality of that? And the empirical literature really is focused on some on mental health, substance use, depression, a little bit on cardiovascular processes, but not a lot of data on outcomes, because it's not a population that's been routinely studied. Now, the CDC has started to report now on risk factors by gender identity and sexual orientation, and I think that is now a little bit, not slowed down, but it's not gone. and so we'll have more data. But the idea of being subject to discrimination in society, I think, was a unifying theme that clinched it for Karen DeSalvo in the department so that she could embrace it and approve it. And then we made the declaration, because that's what the legislation says, that the only one who can declare a disparity population is me, the director of NIMHD, with an agreement with the director of HRQ. And at that time was Andy Beinman, also a UCSF faculty. And so we made that declaration. Of course, I wouldn't be able to do anything if Dr. Collins didn't agree. So, so I think it's up to us to generate more empirical literature to support that. And, in these talks, I can't cover everything, but there's emerging information on this.
So similarly, I guess to build on that, what conversations have you been having potentially with Josh around declaring people with severe mental illnesses as a disparities population, given the 25-year mortality gap and the clear discrimination against that population?
So this has not been discussed, so my answer is none. But I know that it's out there. It's in the literature. People have published on this perspective. So none of the disparity populations that we have either inherited by legislation or declared are characterized by a clinical condition. So I think that would be a line that we haven't crossed. So people have made some persuasive points about disability in general being a disparity population. They are underrepresented group, and so in the diversity programs, it's a category. But in our perspectives, it's not. And I don't have to deal with that problem yet, so I don't have any further comment on it. But I mean, you could say that about many different conditions, although the severe mentally ill is definitely a particular group.
Yeah.
Eliseo, welcome home. My question is reflecting on how do we synthesize all the research that your institute is doing so that it really helps to improve the development of programs and policies. And is this part of what you see as part of the vision or mission of what you're doing? Because it seems that we're not using the data that we have to make improvements. Or, the traditional 17-year gap.
I'm sorry, what was the last comment?
The comment is that there's usually a 17-year gap between evidence and practice.
Yeah. Well, that's a separate discussion. Well, I'll make a couple of comments. First, the standard thing is NIH is not doing policy, we're informing policy, so it's up to others to implement it. I would say that one of my roles as director of NIMHD is to embrace and coordinate these topics across the agency. And I can, it's a challenge. We have developed a new strategic plan. It needs to go through its vetting process, both internally within NIH as well as the department. And so before it gets published, but we have discussed it at length at our council as well as with numerous other, we had listening sessions in different parts of the countries, et cetera. So I do think that across the agency, people will look at that and say, well, this is where we fit here. And most institutes, and we have overlap with every institute at NIH in one way or the other. So we're not like any of the institutes will say, well, this, sometimes NIAID, the infectious disease, will fight with heart, lung, and blood about asthma because they're both inflammatory conditions. And so there are some overlaps in some areas, but we basically overlap with everybody, and so yet we're small. So I think that's a critical role that we have in there. I would argue that things have actually gotten better for the most disadvantaged, for African Americans. If you look at the data in the last 20 years, the increase in life expectancy, decrease in mortality is real. And so what have we been doing right? And so the areas that have really improved have been cardiovascular outcomes. HIV care has made a dramatic difference, more so for minorities, and cancer. Where we've seen consistent decrease in mortality in all groups, but the African Americans have benefited there. Latinos have as well. The opioid use disorder epidemic has really thrown a big wrench on that progress, and particularly borne by low socioeconomic status whites or less privileged, but across all populations, as I'll present it this afternoon. But impacting policy, it depends on the implementation side. And I mean, I could sit and convince myself and convince people with data that's not going to help too much, that by improving access, you really make a difference in disparities. And I think that that's why the empirical evaluation of what happened 4 or 5 years ago with the Affordable Care Act is so critical, because it hasn't been dismantled. And no matter how weak it is or how poor it is in terms of what people say, oh, it's not doing this, but expanding Medicaid did make a big difference. You went from 16, 17% uninsured to less than 10%. Latinos went from over 30% to half, 15, 16% uninsured. And there are, sensitive conditions that one can look at, like how many people have blood pressures controlled, how many people have diabetes. The other policy implication, I think, is that the systems of care need to evolve. And there's a huge West-East dichotomy here. I think most people in California and the West Coast have embraced the accountable care organization, the staff model, HMO model, as the better way to deliver health care, more cost-effective, acceptable to our market economy, and you can actually demonstrate at least as good, if not better, outcomes in many of the conditions that have been studied. It's a wild west in the East. Nobody respects primary care. Everybody's on concierge medicine. Kaiser is small there. And this concept of population health has not been embraced by anyone. And so I think that we have a ways to go. So.
Yeah, well, thank you so much, Eliseo, for being here. We do have to wrap. He'll be here for another 5 minutes for some questions before I whisk him off to ZSFG.